We've got 1 minute before the start. Thank you all for joining on board. We'll just, there it's time. Well, depending on your time zone, good morning, good afternoon, good evening. Welcome to the MECOR webinar on developing a COVID-19 research agenda in low and middle income countries. I think we have over 600 listeners right now from more than 75 countries around the globe. And we want to thank you all for joining us on a really precious Saturday, because we know how busy these days are for everyone. Let me introduce myself. I'm Lisa Chen. I'm the ATS Senior Director for MECOR and a professor of pulmonary and critical care medicine at the University of California, San Francisco. I'm joined here today by my co-moderator, Shannon Carson, chair of the MECOR Steering Committee and a professor of medicine at the University of North Carolina, where he's also chief of pulmonary and critical care medicine. The aim of today's webinar is to bring forward global expert advice really for developing COVID-19 research priorities in low and middle income countries. So hopefully you'll hear some lessons learned from other pandemics. You'll hear great examples of current research activities being done in many countries, and also hear some tips and resources of how you in the audience may launch your own projects. I'd like to say the ATS MECOR team has organized the webinar today, and I'm going to turn things over to Shannon Carson right now to briefly explain what the ATS MECOR program is. Shannon?
Thank you, Lisa, and welcome to you all. In brief, the MECOR program, which stands for Methods in Epidemiologic, Clinical, and Operations Research, is a training program sponsored by the ATS in partnership with professional and academic institutes from around the globe. The goal of the MECOR program is to support local research capacity building by training new investigators in low and middle income settings to design and conduct research relevant to the needs of their local settings. MECOR currently supports courses in Africa, China, India, Indonesia, Latin America, and Turkey in partnership with multiple organizations, many of whom have graciously supported this webinar with speakers today. I'd encourage anyone who is listening today who may be interested in MECOR training to visit the ATS MECOR website for more information. So Lisa, why don't you take over and then get to today's program.
Terrific, thanks Shannon. There's a few notes and reminders just at the very start. So due to the large number of registrants, we're going to have everyone on mute. At the end of the webinar, we're hoping that you might fill out a very quick evaluation just to let us know what other topics are of interest to folks out there in the audience. And know that we are recording this webinar and that a recording will be available via email to all of you, as well as on the ATS site. Feel free to share the link with anyone who's interested. So with that, I am really pleased to thank our entire distinguished international panel of speakers and introduce our first speaker of the day. Dr. Janet Diaz is the head of clinical care within the Health Emergencies Program at the World Health Organization. She's going to speak to us from her global viewpoint on COVID priorities, as well as hopefully give us some lessons learned from pandemics she's been involved with in the past. So thank you, Janet, so much for joining us. I'm going to turn things over to you. I think you're on mute at this moment, Janet. You might, perfect.
Okay, great. Thank you, Lisa, and it's a pleasure to be here. I want to thank you. I want to thank the ATS and the MECOR program for organizing such an important webinar. And for me, it's a pleasure and a privilege to be here and participate and to give you some insights from the WHO. I was asked to describe three things today. One is the global context of COVID. The second was lessons learned from the Ebola outbreak. And the third is research during COVID-19 emergency response. So from this, I'm just going to give you some numbers, as I know many of you are already aware of these statistics. Oh, am I still? Do you still see my slides?
It just disappeared. Go ahead
Oh.
and restart them.
There we are.
There you go.
There are 2.5, over 2 million or 2.5 million cases globally as of yesterday. 212 countries have been affected. 175,000 deaths from 171 countries, and listed here are the top 10 countries with the highest number of cumulative cases. As you see, US, Spain, Italy, Germany, UK, France, Turkey, Iran, China, and the Russian Federation.
Efendim. Ben niye görünmüyorum da ben onları görüyorum.
This graph actually shows you the number of cases reported in the last day, and the dark green is the highest number of cases. So total globally 73,911 new cases. And again, the dark green showing you the most affected places at this time, which I described before, the US, the Russian Federation. We see Brazil, Peru, Ecuador coming in the Paco region, and then a lot of the areas in Europe. Again, the numbers in Africa, and I'm just going to highlight some observations here for you. Lower. And this graph actually, this map actually shows you the number of deaths reported in the last day by country. Again, the total number of deaths globally at 6,675, with the darker colors being the countries with the most deaths reported as of in the past 24 hours, again, mostly being seen in the Northern Hemisphere, the Americas, and in Europe. So how does this look on an epi curve? Here is the curve of confirmed cases that are notified under the IHR from official government sources to the WHO. And we organize our epi here by regions, as you're all familiar with. And so the two major regions affected, as you can see from the maps prior, being Europe in the pink here, in the yellow being the Americas, and then the other regions which are affected but in less numbers. So Africa actually having a total of 16,000 cases, 16,829 cases and 748 deaths reported cumulatively. And you just see it as a little green line at the top here. The next is Sierra with 36,000 cases, 1,517 deaths. And in this graph, it's a little blue line right here. So you see these other regions which are reporting less cases. And then EMRA with 148,000 cases. And the color scheme on this, it's purple. And then WIPRA with 137,000 plus cases with 5,819 deaths. And WIPRA appearing here with this orange color. So I'm gonna give you kind of the framework of the numbers just to kind of put everything into context. And now I'm going to go back to some key lessons learned from Ebola. We've spent the past 2 years in DRC, the Democratic Republic of Congo, in the eastern part, the North Kivu and the Ituri areas, where there's been an ongoing Ebola outbreak. So what did we learn about doing research in that outbreak? Actually, I think we learned 3 major things, and one thing that research can be done. High quality research can be done during outbreaks, and it can be done during outbreaks of emerging infectious diseases, and it can be done in areas that are conflict, where there is conflict, and the North Kivu region has been an area of conflict for over 20 years. So we know in this population, the vulnerable population in that North Kivu area, that we were able to give access to optimized standards of care and therapeutics under ethically approved clinical trial and MURI protocol. And the MURI protocol is a WHO, is the way we discuss, WHO describes the use of compassionate use therapeutics or compassionate use interventions. So it's the monitored emergency use of unregistered interventions, which means that they're unproven therapies. So if they are used, they should be used under ethical approval with informed consent and acknowledgement of the national authorities. So the third lesson learned from the Ebola outbreak was that coordination and collaboration between national investigators, and in the DRC, it was the INRB, which is the National Institute of Biomedical Research, which led the trial in collaboration with international partners. The main partner for this trial was the NIH and international NGOs. Because it was a conflict area, there was many humanitarian actors working with us, including ALIMA, MSF, IMC, Samaritan's Purse, and that coordination was essential for success. And what WHO did in this outbreak for the clinical trial was to play a role of convening and supporting its implementation. So what did we learn from Ebola? We learned that in this area, we were able to optimize supportive care. So this is a picture of the innovation, the cube, which is a biosecure cube that the ALIMA NGO brought into the treatment centers, to many treatment centers, in order to be able to provide more patient-centered care. We made the standard of care at all treatment centers one standard, which included IV hydration, fluid resuscitation, and hemodynamic monitoring, as well as treatment for co-infections. That was standard in all the Ebola treatment centers. And finally, we were able to conduct a randomized controlled trial that tested 4 therapeutics and found that 2 were life-saving for Ebola. So within the scope of 2 years, all of this was able to be done, where every patient who made it to an Ebola treatment unit had access to a investigational therapeutic, either under the randomized controlled trial or under the MURI protocol. So back to COVID. So COVID is much different. COVID's a pandemic. It's affecting 212 countries, and it's rapidly growing, as the numbers show. So it's quite different scenario than what I just described in Ebola, which is concentrated in one country, in one area of one country, and we were able to do that. So what can we do for COVID, though? We just have to expand the scope of what research is, and again, do work more with collaboration and with partners, and do this together. And I think that's what the message is from WHO. So at the early January, the WHO Research and Development group held a summit where many international investigators were present, and they discussed research and the multiple disciplines of research that need to be done for COVID. You know, that includes obviously therapeutics and the race for finding an effective medicine to treat COVID-19. The second, obviously, vaccines, the race to create a new vaccine to stop, to prevent disease. Diagnostics, how can we make better diagnostics, faster diagnostics, point of care diagnostics. IPC, how do we stop transmission and keep our healthcare workers safe? And we know there's a tremendous number of healthcare workers that have been infected during this pandemic. And what can we do better? Clinical characterization and management, and that's actually the working group that I chair, that I lead, and that's one focuses, and I'm going to speak a little bit more about that. And then, of course, research in the areas of risk communication, community engagement, and ethics. I'm going to focus on 2 parts that are related, I think, topically to the ATS and to the clinical management side, where my focus is at the WHO. The first is the WHO Solidarity Trial. So the concept behind this was building on what we did in Ebola outbreak in DRC. So the need here was for speed and scale and putting up a trial quickly. And then the idea was to enroll patients into one single randomized trial to help facilitate the rapid worldwide comparison of unproven treatments. And we wanted to do this quickly to avoid the use of unproven therapies outside of clinical trials of MURI. And you know, this has been a big challenge in the past 3 months, where there is extensive use of unproven therapies outside of clinical protocols using compassionate use. And you know, the risks of that practice is highly concerning to us. So the one single study aims to overcome the risk of multiple small studies not generating the strong evidence to determine effectiveness of these treatments, you know, safety and efficacy. And so now we see that there are small trials being published, and some of them are stopping to enroll a little bit too early, and so the results will be difficult to interpret. So we're hoping one large single trial will be able to find results. And so the Solidarity Trial also is providing simplified procedures to enable even very busy hospitals to participate with a common DSMB, a common data platform for inputting your data. And as of this point, I talked to my colleagues who are in charge of this. Over 100 countries are working together in this trial. So I think this is a big feat, and I would encourage countries that are wanting to participate in the study to get in touch with us, because we are welcoming all countries. What else is on the research agenda? And this is just, you know, some of the priorities that came out of our WHO Clinical Characterization and Management Research Working Group. One is the collection of standardized clinical data, so a core case record form to characterize COVID-19 disease in different contexts. And I think this is extremely important to this to the audience here, that the collection of data to understand the disease in sub-Saharan Africa, in resource-limited settings, in other contexts is important. Right now, we're understanding there's publications coming out from, you know, Europe and from China and from the US, but we need to see what the disease looks like in other parts of the world. And so the WHO does have a core CRF and a core COVID clinical platform that you can actually share your data with the WHO in order for us to try to look and aggregate data globally and look at the clinical disease in different settings. Also, use of a core minimal outcome set. So this is useful for those of you who will be doing studies. And if we use at least a minimal core outcome set, then it'll be easier for us to kind of aggregate different studies at a later date, or even during the studies, if we were able to do that in order to strengthen analysis. And thirdly, here is, how do we optimize supportive care? One of the major things we're trying to work on is the improving access to oxygen. And maybe that's not a research question necessarily, but it is an implementation and operational aspect that is true to many countries around the world where oxygen systems are not strong enough. So can we use this opportunity to improve access to oxygen and input more sustainable oxygen systems in countries that are lacking? And then, of course, the look at high flow oxygen, which I'm sure people will discuss, or other advanced respiratory support interventions such as CPAP, non-invasive ventilation, high flow oxygen, to improve outcomes and reduce mortality. We are seeing a variation in global mortality in intensive care. Some countries reporting as high as 90%, and others, you know, and then the majority looking around 50%. So the mortality is high. Is there anything we can do better in the ICU setting, and especially in countries where this mortality is being reported at very high levels? Other things that have come up in our group include the role of steroids, anticoagulation, ACE inhibitors, ARBs, as I'm sure you may discuss, the use of severity scoring systems to guide hospital bed use, following up survivors. You know, what is it? What is a COVID-19? Someone who recovers from COVID-19? How are they after? Especially those that are hospitalized and develop severe or critical illness, and cohorts on pregnant women and children. Although it seems like there's not you know, an association between, although it seems at large right now from what we see that there's not an association between pregnancy and having severe disease or children, but I think ensuring that we have enough cohort data on these special vulnerable populations is also important. So with that, I want to thank you. Those are some foods for thought. These are our websites at the WHO R&D program, the WHO technical guidance, where you can get more information about many of these initiatives. So I want to thank you, and I wish you guys, I wish us a very good rest of our webinar. Over.
Terrific. Thank you, Janet. That was really wonderful. It was a great way to start us off. And now it's my great pleasure to introduce our next speaker, Dr. Jeremiah Chikaya. Dr. Chikaya is a representative from the Pan-African Thoracic Society, where he serves on the executive committee and was a founding member of the Kenyan Thoracic Society. He's held numerous leadership positions for TB technical advisory groups, including both for the WHO and Global Fund, and he's currently a professor of global respiratory health for the Liverpool School of Tropical Medicine. Dr. Chikaya will provide a perspective on research priorities and concerns really specific to the African context, and we really pleased that you can find the time, Chikaya. I'll hand the mic over to you. Thank you.
Thank you, Lisa, and thank you to the organizers for the opportunity to speak at this webinar. An important engagement for sure for the Pan-African Thoracic Society and many people in Africa, because COVID-19 is certainly worrying all of us. I wonder if we can show those slides now. I'm not able to see them yet.
Yeah, I think Nicole is working on that. We're not seeing it yet, Nicole. There you go.
All right, let's go to the next slide, please.
Yeah, weird. When I put it in like the slideshow, it like doesn't show anymore.
Okay.
All right, okay. We'll have to live with that, and I'm sorry.
How about like
people,
this?
but we have to live with that. So,
Man, okay.
it's all right. Let's just do the way we do it. Let's see how it will come out. So the numbers have already been highlighted by Janet, but I think it's important for us to know that this is a big issue now across the world. It's worrying all of us. Fortunately for us at the moment, the numbers in Africa, if we can go to the next slide, the numbers in Africa.
Sorry, I'm going to change the presenter really quickly because it looks like my colleague will be able to present them in full screen. One moment.
Thank you.
There we are. Beautiful.
Thank you so much. So these are the numbers, and Janet has already gone through these numbers. A very worrying trend for sure at this moment in time. Numbers are still going up both for new cases and cumulative cases and the deaths. So we haven't seen anything like getting to the peak or beginning to come down with the numbers globally. A very worrying trend indeed. Next slide, please. So this has already been shown also. If you look at this figure, Africa seems to be at the lower end of this pandemic. We are still seeing a low-level pandemic. And if you look at the next slide, it might explain some of these things. The numbers in Africa, if we can go to the next slide, the numbers in Africa for a few selected countries that I wanted to highlight here, other than for South Africa, that seems to have taken off with increasing daily numbers over the last 40 days or so. Many other countries in Africa, we are seeing numbers that are bubbling up and down, as it were. So you get, 40 today and 10 cases the following day, and we don't know how long this kind of thing is going to happen in the African setting. However, there are very worrying trends based on modeling studies that have been done for Africa. If we can go to the next slide, please. Next slide, please. So this is modeling work. Not the next. Please go back to the previous slide, please. So this is modeling work, looking at the projections of the numbers that are going to may happen in Africa, and these are really worrying. It is projected by researchers that by end of June, for example, 16 million, more than 16 million infections will happen in Africa. Of course, you can see the confidence intervals are really broad, which means there's a lot of uncertainties about this number. But if this kind of thing is going to happen in Africa, it's going to be an extremely worrying problem. Next slide, please. So I just wanted to deal with what we know at this moment in time, because what we know is what is going to shape our research agenda going forward, like what Janet has said. So we know something about transmission. We know that the main mode of transmission is droplet, but there's a little bit of transmission that goes on with the aerosolization. And there's the increasing recognition that asymptomatic or pre-symptomatic individuals may be driving this pandemic in many parts of the world. Next slide, please. In terms of morbidity and mortality, if we can go to the next slide, we know that the majority of people have a mild or asymptomatic disease, but then about 20% of people have serious or critical illness. If you look at the figures from Africa, since Africa started reporting cases, and you look at all the cases that have been reported and the mortality, just do a very simple arithmetic, look at the number of people who have died versus the people who've been notified, you see a mortality rate of 5%, which is significantly higher than the early experiences in places like China. So this is worrying for Africa. If we're going to end up with those kind of mortality rates, it means potentially lots of people could lose their lives from this pandemic going forward. Next slide, please. Next slide, please. So we need radiology. Next slide, please. We need radiology, both chest x-rays and CT scans. Those of you who've been dealing with TB for many years know that these are a huge problem. Access to the chest radiograph or access to the CT scan is a big problem in the African setting, not just in the African setting, in many low and middle income countries. And so there you have your problem already. How are we going to be able to make it possible for a lot of people to be diagnosed, to have this infection and this disease in settings where access to basic services such as radiology services is very common. Next slide, please. Next slide, please. We know, based on the cohorts that have been reported now, we know that there are certain groups of people that are at increased risk of dying. I wanted to highlight some of these issues because they are important for Africa, as you will see when I project the next slide. If we can have the next slide, please. So this is Africa, and in Africa, all these things are important to us. We've got a high, we carry 68% of the burden of HIV, for example. The large proportion of the African population is poor. We have a lot of TB, nearly maybe 20–30% of the global burden of TB is in Africa. We've got a lot of post-TB chronic lung disease. We have COPD as a big problem. We've got occupational lung disease as a major issue in the African setting, especially in those situations where mining activities are common. So you're looking at the population in Southern Africa, Lesotho, Botswana, South Africa itself, and Namibia and other places. And all these things, we have no idea at this moment what the situation will be like once the pandemic takes root in the African setting. If you see people starting off with lungs that are like the ones that is projected here, and then you develop the kind of respiratory illness that COVID-19 is, it may be that in fact in the African setting, the situation will really become very, very difficult. Next slide, please. So it is, I think, important for us to assess whether in fact case fatalities will be high in sub-Saharan Africa for the two reasons that I have highlighted here: the abundance of persons that are at risk of severe disease and with very weak healthcare systems that are unlikely to be able to cope with the numbers that we've had or we have seen in places like China, Italy, France, and other places. If in fact the pandemic evolves to what it is doing currently in those parts of the world, then our healthcare system will be very easily overwhelmed. And we have problems with the quality of care, which may not match the need or the complexity of this disease. Recently, a paper was published from Malawi, for example, showing that only 11% of people who are hypoxic in that country have access to oxygen, like Janet has said. And oxygen will be a key therapeutic intervention for patients with COVID-19. And how do we then, like it's already been mentioned, how do we make oxygen supply systems robust in our continent? Next slide, please. So in terms of going forward and thinking about the research agenda, I thought I would divide what we need to know about the pandemic in Africa into three categories. We still do not know about the transmission dynamics in the African setting. There's been some thought in some places that maybe weather may help us. For example, the African continent is largely warm, except maybe the southern tip. Would that be helpful? I don't know. What will be the role of reinfections? We do not know. What populations are going to have severe disease or death? So these are all things that really require to be studied in our situation. We know that non-pharmaceutical interventions that have been promoted by the World Health Organization are really great. Studies from China suggest that they actually did help to reduce the pandemic in that country. But there are difficulties in places where the population is so poor. 70% of the African population depends on informal employment, and they depend on day-to-day wages, and you cannot really keep them indoors because you've locked down the country to control transmission of this infection. And so I think Africans will need to start looking at what interventions are most effective, and maybe also look at cost effectiveness studies. Do we adopt the entire package, or can we adopt some packages? Can we allow some parts of the economy to continue? And if we are going to allow or open up parts of the economy to continue, what is it that we will need to do to be able to ensure that we do not end up with we suppress the pandemic, but at the same time allow people to continue doing what they need to do for daily living? The issue of how to provide care to people of COVID-19 disease is extremely important. I am imagining that at the end of the day, if this pandemic takes root in Africa, it may be that, and Africa, as we all know, is still primarily, the population of Africa is primarily rural, and therefore, in a hierarchical healthcare system, what would need to be provided at the primary healthcare level vis-a-vis what can be provided at the tertiary care level. I think those are really important issues. The health system research that needs to be done to deliver the best possible care for the best possible outcomes. And if we are going to do that, then we will have to think about the kind of care teams and trainings and what have you that will need to be developed at the various levels of the healthcare systems. And I'm really talking here about health systems and implementation research. In the critical care settings, and I know a lot of countries are trying very hard to develop critical care capacity within the African setting. But at this moment in time, we do not know what care protocols will optimize outcomes. And so I was happy to hear what WHO is suggesting should happen. But these are things that need to happen in our own country to be able to define what treatment needs to be given to people. Like, for example, would we have to prone most people when they are on oxygen before we ventilate them, or should we only prone them after we have debated them. All those are important issues that we need to think about at a critical care setting. We are many countries in this in our part of the world logging on, or rather hooking up to the clinical trials that are being advanced by WHO, and I think that's a really good thing. But I think one very important thing is that even though we are currently dealing with this pandemic, the other problems have not gone away. So HIV hasn't gone away, TB hasn't gone away, malaria hasn't gone away, other diarrheal diseases haven't gone away. And if you remember with the Ebola epidemic several years ago, in countries like Liberia and Sierra Leone and Guinea and what have you, maternal mortality went up, malaria deaths went up, and TB deaths went up. And so the issue, therefore, is as we provide care for COVID-19, how do we continue to provide essential services for endemic health problems in the sub-Saharan African continent? And there are many research issues that we need to think about as we go along. Next slide, and I think that was probably the last slide. Thank you.
Thank you very much, Chikaya. I think I'm going to scoot us right along to our next speaker. I just do want to ask the audience, we may run a little late, and we're hoping that maybe you could stay on board because there's still going to be a very good discussion. So it's wonderful to have our next speaker, Dr. Mark Cohen. He's the Vice President of the Latin America Thoracic Society and a critical care specialist and researcher from Guatemala City. And he's going to provide a perspective on the challenges and opportunities specific to research in the Latin America context, and a lot of examples of great research being launched there and a lot of collaborative efforts. So thank you very much for joining us, Dr. Cohen. I'll hand over to you.
Thank you, Lisa, and I want to thank ATS and all the MECOR webinar members today. Thanks for the audience, either morning, afternoon, or night in several parts of the world. I was asked by the Latin American MECOR Steering Committee to talk a little bit about what we can do in Latin America. And we know that we have a lot of advantages in Latin America. One is we have a very high population of 6 million people in 22 countries. Even though we do have a diverse population and geography, we only have 2 languages or that prevalent that makes it very easy to be able to do a lot of research and surveys in the whole region. But lack of independent and government funding really allows us only to do observational and descriptive type of study designs that can be done in our countries in Latin America. This has been kind of presented globally. We have more than 2.5 million confirmed cases, but trying to contrast the high income countries, US, Canada, and Europe, versus our 3 regions with the low or medium income countries. And I want to emphasize that Latin America is one of the regions with the highest confirmed cases of the lower and middle income countries. We also have a high increased deaths in our region, and that really makes us have to work on doing a lot of epidemiologic as well as therapeutic trials to try to improve this. This is what PubMed has been publishing. There's 8 articles from Latin America, Brazil, Ecuador, Chile, and Bolivia, but a lot of these are just descriptive cases, and that's how everything is being started on, and we want to do a little bit more formal research in the future. I really liked this article that was just published ahead of press, and they took the experience of SARS and MERS and the recommended study designs that were done then are trying to be improved for the COVID-19. And I would recommend going into this article. It gives us key questions of research as well as recommended study designs. And our steering committee has decided to work on 3 of these questions, and then 1 that's already being done with ongoing studies for randomized controlled trials in our area. I'll be talking about what ALAT is doing in Latin America to try to join collaboration between clinicians and researchers in doing e-teaching. We'll talk about a case series that we are starting to model, and then 2 surveys that we would like to do in our areas, and I'll present what is being done in ongoing studies in Latin America. Before starting, we wanted to make sure that a lot of people would be interested, and we just had a week ago a very interesting webinar about KSeries studies and the importance of doing KSeries studies, and knowing that KSeries don't have the higher evidence in the pyramid, but we also know that large and high quality KSeries can really open up this scenario for further research and able to really be able to do the presentation of new clinical science and studies and therapeutics in our area. So this is in our website. This is our website there that you can hear it. It is in Spanish, but in this webinar, also in our question and discussion, we decided that we needed to have a site in our website about networking with researchers, giving their proposals or if they're already doing studies, and then having a Q&A section for all those MECOR family in Latin America. The steering committee from ALAT and MECOR also decided to do 3 studies for the COVID-19. The first is a case series, and we want to do a prospective and retrospective case series study, being multicentric, on critical care and non-critical care patients. And we would be using the Remap Cap platform. And as Janet said, we have been discussing, are we going to be using the WHO CRF, or are we going to be doing our own CRF, accommodating for the locality in each place? And then we would like to get clinical presentation and prognosis according to ethnicity, gender, age, comorbidities, disease severity, and then geographical latitude and altitude, because we have so many high altitude countries in Latin America, and climate, to see if there's any changes in the clinical presentation and prognosis. And then, of course, we want to evaluate the outcomes for the pharmacological therapies, either the RCTs or, like Janet was also saying, for those compassionate therapeutics in areas that we can't do RCTs. Mechanical ventilation modalities, are they proning? Are they being successful with the proning, either with non-invasive or invasive? And then the renal replacement therapy and ECMO that is done in several countries in Latin America. And of course, we would like to use this information to be able to compare with other case series worldwide. Then the other 2 projects are surveys. First is really, we want to survey what the healthcare access is in our different countries and in different cities being between countries concerning the personal protective equipment, if there's access to them. How about COVID testing, imaging? Do we have just X-ray, ultrasound, CTs? How is your staffing in each hospital in the countries? The total number of beds and ICU beds, and if they have the access to video laryngoscopes to do elective intubations to reduce contamination for the personnel. And then the number of ventilators in each country or hospital, and the type of ventilators being used. And then, like I said, try to survey the treatment options that are being offered. That would be one of the surveys. The second survey is really the psychological effects, the fears and concerns of our healthcare workers. And that includes everybody, doctors, students, nurses, RTs, techs, housekeeping, and EMS personnel that's taking care of these patients. And we would like to survey their fears and concerns of safety. What happens if the fear of getting sick, transmitting this to their loved ones back home, not having the rapid access to COVID testing so that they don't contaminate the rest of the people. And then, of course, luckily, we haven't gotten to that point in the majority of countries, but in some countries, the avalanche of cases are coming in, and we have insufficient staffing or equipment. And then people are being transferred out of the ORs out to the floor or to the ICUs, and they're not used to that. And then also, all the specialists are dealing with pulmonary and critical care medicine right now. Surgeons having to take care of critical care patients with ventilators, rheumatology specialists, everybody is helping when the avalanche comes in. So that brings a lot of stress. And then not only stress, but long hours of work will turn out in burnout syndrome. And we're getting to the point of having to have advanced directives to deciding who gets or doesn't get full therapy. And some people aren't ready to deal with these advanced directives, and that poses a lot of stress to our healthcare workers. And then for institutions, what support can we give our personnel and families if they get sick, assuring job security, and then also having access to psychological support line. We want to see if there is all these support in the different countries of Latin America in this survey. I just put a couple of our ongoing studies that are a little bit more formal, 2 in Brazil, mainly for critical care, and doing more physiologic for the inflammation cytokines, and Rogelio Perez Padilla in Mexico is included in the RCT of hydrochloroquine as treatment for severe COPD, and then also for post-exposure of healthcare workers. Then there's also prediction models for public health planning in Honduras, and one interesting study in Colombia by Barón and Giraldo using homemade or local made ventilators versus the ICU ventilators, and seeing the viability and safety of use of these ventilators, since we have scarcity of ventilators in a lot of the countries of Latin America, and there's a lot of new ICU vents made locally, not for the high severity cases, but for the mild and moderate cases, probably that could be used. In conclusion, despite many limitations in Latin America, it's a very active site for research, and it's plausible to do these studies. This pandemic is a great opportunity to join forces between the clinicians and researchers, and especially our MECOR family can contribute tremendously to develop high quality research in our region. And ALAT platform has to expand its online teaching and networking on investigational methods as well as research opportunities. And lastly, ALAT is compromised in, like I said, doing at least 1 large KSeries study and 2 surveys, apart from the ongoing research already done, to expand our knowledge on this disease. I think we really need to take advantage, and like Janet said, even in the epidemics, we can do research, and I think we should try to really take advantage and learn a lot in our region. Thank you. Thank you very much.
Mark, that was just terrific. And I knew ALAT was going to come out with some really thought-provoking and wonderful ideas. And I'm sure you're going to get people writing to you, hoping to maybe share in some of your protocols and ideas, because I think they could be replicated in other regions. So our last speaker before our panel discussion, I'm really pleased to bring on board our very own MECOR faculty member, Neil Adhikari, who's going to give research advice that speaks to really practical, general issues that we hope he can share with folks listening who are about to launch their own ideas. Neil is an assistant professor at the University of Toronto and an associate scientist and intensivist at the Sunnybrook Health Science Center, and involved with many global research projects on lung health. So welcome, Neil. So glad you could join us.
Thanks very much for the invitation, Lisa. And can people see my slides?
They look perfect.
Okay, I'll take that as a yes. Thank you. Okay, so I'm going to talk about some, I guess, general research issues, maybe echo a bit of what Janet said, and then maybe talk about some specific practical issues. So I think these are my take-home messages. There's already been a lot of talk about collaboration. I'm going to just echo that and say how important that is. I will also echo that observational research is very valuable, not only from because it may be more feasible, but also because the insights generated from it are, I think, quite important. I think for randomized trials, which are totally important, it's important to prioritize those that have a global scale and potential global impact, and that includes the WHO Solidarity Trial. I think a couple of practical points that I'll talk about are the importance of working with ethical committees, which in many parts of the world are just not used to working either with the hours or with the speed that's required in order to move research forward during a pandemic. And then I'll mention briefly just a point about making data collection as simple as possible. So the traditional challenge of pandemic research, and I think this was pretty obvious in H1N1 in 2009 and in the West Africa Ebola outbreak in 2014 to 16, is that pandemic starts, it takes a while for a study to get designed. By the time you submit an ethics application and get funding and approval and you initiate sites and legal contracts and so on, the pandemic is on its way down, and you may not be able to complete your study, and your study may not be relevant. And certainly from Ebola in 2014 to 16, that was pretty clear, with really only one prominent randomized trial being completed of therapeutics, and the vaccine trial just sort of making in by the skin of its teeth, showing effectiveness of the vaccine before cases decreased. That's changed with this pandemic, and I think there's, as you've seen and heard, there's a global commitment which has been coordinated by WHO to prioritizing research questions, to developing platform approaches to answering questions where there's a lot of collaborators asking the same questions but maybe not having exactly the same operations to answer the research in different jurisdictions, and also, and importantly, a global commitment to data sharing. And a lot of this wasn't developed now, it was sort of developed after previous pandemics, but it's really come to fruition now. What are the local challenges that's remaining? Well, I think everyone probably listening can appreciate that it's very difficult to make time for research when there's very pressing commitments to look after patients. The availability of funding on a global scale is very variable, and as in the case in the past, it's much more available in high and upper middle income countries than in lower middle and low income countries. And I think a third challenge that may be especially true in some jurisdictions is the willingness and adaptability of ethics committees and regulatory body to act in an expedited and efficient manner to accommodate research being done. So just to emphasize the research roadmap that was published in March after a meeting in February, the meeting actually happened before the pandemic was declared. And I'll highlight a couple points from here. One is that the roadmap was meant to identify research priorities. It wasn't meant to dictate what got done, but it was meant to identify priorities that researchers could consider as they design their own work. The WHO felt that it was important to coordinate research so that results of research could be shared with WHO and lessons promptly disseminated, rather than sort of waiting for the usual peer review and publication process, which happens at too slow a pace to actually help patients when there's important findings that are made. Fair and equitable access to data and also to treatments that are identified as useful from ongoing research. And then I think an important point in this research roadmap was that whatever is learned in this pandemic shouldn't be put on the shelf, but should really be applied to future pandemics, which are expected to happen. This paper just came out maybe in the last month from a group of investigators who formed a coalition to accelerate clinical research on COVID-19 in resource-limited settings. The first point they made which was as of a month ago, there were just over 300 COVID-related randomized trials, but very few of them at that point had been planned in Africa, South and Southeast Asia, or Latin America. They made the generic point that high priority interventions would have to be affordable to the population where they would potentially be used, ultimately available and adaptable to their systems and population. And they identified a variety of areas where trials were needed, not just related to specific medical interventions for specific patients, They identified multiple challenges in launching trials, everything from provision of trial materials, databases, statistical support, and so on, and lots of barriers as well, not surprisingly. So with that, what's currently available? Well, this is, Janet already referred to this. This is the WHO Global Clinical Platform, which is supporting an observational study. The whole CRF is 5 pages long, and it only has to be 5 pages if you do these 3 modules on the day of admission to the hospital or health center, the first day of admission to an ICU or high dependency unit, and on discharge or death. If you choose to do the daily modules in high dependency or intensive care, then it's longer, but it's actually fairly abbreviated and will be, I think, a core observational study that will generate predictive models and among patients that are admitted to hospital and to ICU. This is adapted from the ASARIC clinical characterization protocol. ASARIC is an international consortium of mostly infectious diseases physicians that are interested in a severe acute respiratory infection. And they have case report forms and also a data capture system where data is stored centrally in the UK, but everyone sort of has access to it. And they have a rapid case report form, which is what was adapted by the WHO, and also a slightly longer core case report form that allows for more data collection. And these case report forms are modular and allow for the addition of different modules locally. The Solidarity trial was mentioned. I've heard that there are over 2,000 patients recruited into this, and the patients in Solidarity are hospitalized and are randomized to either local standard of care or standard of care plus one of these antiretroviral treatments. It's an open label study. Importantly, the WHO isn't providing funding for this, so there has to be some sort of local funding mechanism to do this. But as far as trials go, it's extremely lean, and the data collection for this is very efficient. I'll mention Remap Cap, which is a platform trial that was designed a few years ago as a way to study community-acquired pneumonia indefinitely. So it's a very efficient trial and clever trial in the sense that it takes patients with severe community-acquired pneumonia and it has multiple domains of interventions. So you can think of an antibiotic domain, a mechanical ventilation domain, an immunomodulatory domain, and it has responsive adaptive randomization, so that if within one of the domains a particular regimen is looking promising, say steroids in the steroid domain, then more patients would be randomized to steroids, and data are analyzed continuously or weekly, so that there are triggers to declare when a treatment is useless, when it's harmful, and when it's superior, which would lead to changes in clinical practice. And this protocol has now been adapted for COVID, and there's now Remap COVID core protocol, which is not just for critically ill patients, but also those on hospital wards. And it includes an antiviral domain, an immunomodulatory domain, and other domains that are being developed, including heparin for what many perceive as the problem of pulmonary emboli and small vessel clots that are seen in these patients, vitamin C and other domains. So this, I think, is another sort of practical global trial with a relatively lean data collection. However, it doesn't come with its own funding. That sort of has to be borne by the institutions that are enrolling in this trial. Other examples of research priorities, this is a paper that came out recently in the Blue Journal from a US first author, but from different authors globally among the author list, identifying some other research priorities that could be identified. I think probably the people on this call can think of other research priorities. Here are some that came to mind to me just in the last several hours. research priorities around supportive care for sick patients, particularly the use of high flow nasal cannula. When can it be used and can it be used safely? The point that was made earlier on whether awake proning reduces the need for invasive ventilation, which may be in very limited supply. Outcomes of COVID-19 in vulnerable populations, long-term outcomes. And I think it's important to also recognize that this pandemic may have adverse effects on patients who don't have COVID-19. And that's, I think, also potentially a research priority worth investigating. So what about ethics reviews? So even within the city where I work in Toronto, there are hospitals that have a reputation of being reasonable on ethics review and others that have a reputation of being very obstructive and slow. And I think it's important to recognize that clinicians looking after patients and doing clinical research should partner with the ethics committee and work with them. And I think a key principle to impart is that in a pandemic especially, research is equally important to clinical care, and clinical care will never get better for the thousands and hundreds of thousands and potentially millions of future patients that will be infected over the next year unless high quality research is completed efficiently and rapidly. And for an ethics committee point of view, that means that review of projects should be expedited. It means that within centers where there may be many projects submitted to the Research Ethics Board, the Research Ethics Board needs to conduct sort of a mini scientific review to prioritize on an institutional level which projects get prioritized, because otherwise, even within the same institution, there may be lack of coordination with respect to conducting projects. And I'll say that the Research Ethics Boards, especially for trials, really needs to wrap its head around alternative consent models to first-person signed written consent from the patient, because that is not going to be possible in the pandemic. And alternatives such as telephone consent, deferred consent, waiver of consent should be considered. And these are this was identified by WHO as important 5 years ago in a document. And they make the point, which is true, that a lot of these are supported or can be supported by rapid community engagement via virtual focus groups and so on around consent models for sick patients with COVID. What about data collection? I think this is true, and students of MECOR will know that this point is made repeatedly, that the case report form should be reduced to what's truly essential to answer the primary research question, but especially in a pandemic where you're potentially asking your research staff to collect data in COVID units from charts and so on. It's really important to pare down the CRF to what's important. Some of the data might be able to be collected remotely if electronic records are available. Some of the data may be able to be collected retrospectively after things have settled down. But for data that needs to be collected at the bedside, I think ensuring the safety of research staff is important. And it's not impossible. Research staff can be provided PPE where available and as recommended by the institution. And most importantly, they can be trained by clinician investigator, principal investigators on how to use that appropriately. But I think modification of consent models and remote data collection and retrospective data collection are all methods that are important to limit the exposure of research staff to patients where that's appropriate. This is just an example of some resources from the NIH Fogarty Centers, and I'll just highlight this African Forum for Research and Education and Health, which has a monthly webinar series, and this course from Vanderbilt, which has some teleeducation for healthcare providers on COVID-19 that includes some discussion about research in addition to the open WHO course series. And I'll stop here with the same take-home messages of collaboration being important, valuing observational research if you don't have the logistical capacity to do trials, and if you do a trial, prioritizing trials that will have global impact, working with ethics committees to facilitate the rapid review and conduct of research, and simplifying data collection. And with that, I'll stop. Thank you.
Well, thanks, Neil. Really, to all four of you, a terrific set of presentations, really thought-provoking, lots of really good information. I think what our listeners are hoping to get. To our audience, you can tell we're running late. We'd still like to go ahead. For those of you who could stay on board, we're going to run about another 10-15 minute discussion session, and I'm going to turn it over to Shannon Carson to run this and close the series out. So thank you all very much, and let's hear some ideas in the discussion. Thank you.
Good. Thank you very much, Lisa. I'd also like to introduce Dr. Erlina Burhan, who is the MECOR Indonesia co-director and pulmonary and critical care specialist at Persahabatan Hospital in Jakarta, and a leadership representative of the Indonesian Society of Respirology, and also Dr. Zuhal Karakurt, who is the MECOR Turkey co-director and associate professor in the Department of Pulmonary and Critical Care and Health Sciences, University of Surayapada, and chief physician of the Surayapada Chest Disease and Thoracic Surgery Hospital in Istanbul, Turkey. So thank you, Zuhal and Erlina, also for joining us. First question is to Erlina and Zuhal. We've heard a number of our presenters talk about standard data set, minimal data sets for patient outcomes, things like that. One of the presenters talked about some of the issues with the ethics boards and getting those up and running. So both of you are managing hospitals that are essentially COVID hospitals now in large urban centers in middle income countries. Have you been able to institute a standard data collection instrument for COVID-19 patient outcomes? And what kind of barriers have you experienced in trying to do that, and how have you overcome those? So Zuhal, why don't you go first? You need to unmute, Zuhal.
Can you hear me?
Yes, we can, Zuhal.
Okay.
Thank you.
Okay. Thank you for your invitation. It's an honor for me. In my country, there is standard data entry program. Each hospital responsible person, generally chief in hospital, this is the responsible one. It's something secret personal data entering system. That's why this responsible give to the head of hospital. It's a very big issue and very difficult issue. There are so many parameters that we should enter 2 times a day, in the morning and the afternoon. I mean, like near dinner time. The physical appearance, tomographic features, and the drugs, and the complications, and the jobs, and the coronavirus contact person, and health workers or not. If health workers, what kind of health workers, physicians, nurse, and other supportive personnel, so on. It's very good protocol, I mean program. Every part of Turkey do it each day, and after dinner, the Minister of Health government gather the information and give speech to Turkey. The numbers and intubation numbers, ICU patient, how many patient die. If we do something late, putting the items, then the gathering information a bit late. It all these data interval inflate because of our problem, our fault, let's say. And the government tell them the numbers, look at these data. But at the end of this pandemic, Turkey have very rich big data about the coronavirus, I mean COVID-19. So we can share our information, our experience to all over the world. My suggestion to MICOR country, we can do this year MICOR on topic COVID-19. We can project our project based on, focused on COVID-19. It's maybe helpful for all over the world, and ATS maybe have opportunity to take connection the ATS science and the COVID-19. Maybe future information helpful.
Good. Well, thank you, Zahal. That sounds like a good example of maybe taking a government administrative and disease tracking data set and then exploring it from a research point of view on patient outcomes and risk factors and such. Erlina, what's your experience been?
Okay, thank you, Shannon. It was a very, very nice presentation from all the panelists. I just would like to share my experience or to share first the situation in Indonesia. So the COVID cases are increasing day by day. It's already reached 8,000 cases by now, and 6,000 of them already being hospitalized, and with the 689 patient death. And also in my hospital, in a month we have around 200 COVID positive in my hospital, Persahabatan Hospital. And there are 3 research area that we are thinking about. Well, first, let me share the good news. So, regarding this COVID disease now, our ethic committee in the hospital is very, very generous. So the approval we got is very, very fast. We can get approval in 1 week if there is about COVID. So I think the government has make like pushing the ethic committee to give approval in a very fast track. So let me share with you the area of research that we are planning in Indonesia. There are 3 areas. One is tracking and testing, and this is more like a surveillance data. And second is treating. With this treating or treatment area, there are already many research going on. As mentioned by Janet, the solidarity trial is also already launched in Indonesia, and also will be coming soon the remdesivir trial. This is, I think, is under NIH or something, or NIAD. I don't know, either one of them. And then there are many trial regarding this treatment. For instance, it will be a tocilizumab trial, and we are also now and
Okay, Erlina, I think you're breaking up a little bit from your internet connection, but what we gathered is that your ethics committee is actually has adapted quite quickly to the COVID epidemic, which has allowed you to get a number of clinical trials up and going, including the Solidarity trial, which is fantastic, and then a remdesivir trial also. So that's good. It's good to hear that some of the principles that have been laid out by our speakers are already going well in some of our larger hospitals in our key middle income countries. Let me ask the panel as a group, what do you think, particularly in Africa and some of the other lower income countries, where's the progress on using telehealth interventions or electronic cell phone surveillance interventions for both disease tracking, disease management, and importantly for epidemiologic and even clinical research?
At least in Latin America, we don't have any of the surveillance using our cell phones, but of course there's experience in China and other parts for this, but that I know of, there is no implementation in our region yet.
Yeah, Dr. Chikaya, what's some of your experience in Africa, or Dr. Diaz? With telehealth or cell phone interventions for patient-centered outcomes?
There's been a lot of talk about these issues and a great desire to actually use telemedicine for providing patient care and consultation, and also using digital platforms for surveillance purposes. But as far as I know, I'm not aware of any major research project that is going on at this moment in this area. But it's something that I think we need to put forward with. But I'm not aware of any particular research project that is doing this. Maybe partly because, like I already said, the pandemic is still at a fairly low level in the African continent.
Mm-hmm. Good. A couple of you had mentioned concerns about maintenance of research and also healthcare delivery for some of the key medical issues or endemic diseases like tuberculosis, HIV, or malnutrition. How would you imagine turning some of those operational concerns into operational research opportunities for MECOR students or other investigators in your countries about how to provide research and information about how to keep some of those key programs active and effective?
Shannon, can I say something?
Please, Erlina.
Yeah. So those data that you are talking about, especially with data of surveillance, those data are managed by Ministry of Health and also Provincial Health Office. So we are in the hospital, we do not really get access to that data unless we can them. But I mean, it's not a system that we can easily get the data from the Provincial Health Office. But actually, they are the one who have the data, and I think they are using also a digital and electronic thing. So we have to make an effort to make a collaboration with them to get those kind of data.
Okay, good. So maybe linking with some either government or health ministry resources that are utilizing telehealth and then collaborating with them for research questions. Okay, good. All right. Any other recommendations for forming collaborations on clinical intervention research? We've heard about the WHO trial format and the Remap trial format. If there are other innovative interventions that aren't part of those networks, do you, maybe Dr. Cohen, do you have advice for how providers at different centers in a region can band together and collaborate on some multi-center trials of 8, 10, or 12 centers within a region? What's been effective within ALAT and Latin America MECOR for pulling together some of those collaborations? What have been key operational aspects there that allow some of those to come together?
Yeah, I think it's not an easy job because there's different chiefs in each country, and it's hard to break the collaboration from everybody, especially doing the format, the CRF. Some people want one thing, other people want others. So we need to make it simple and getting the most important information from those CRFs. So I think we need to modify our CRF platform to really include the most important hospitals taking care of the COVID-19. Right now, what we're planning is talking to our members from ALAT, and then for them to be our messengers in their own countries to try to get our group in the country to get all this information and do a collaborate unified format, and then get that information and compare it with the countries. I think that's probably the hardest, getting and collecting the data that we can have people that like to do a lot of research, put in the data and everything, but that collaboration of people and opening up, I think it's the part that we need to work more.
Good. Well, I think that's a good note of in part success and in part challenge for all of our investigators, and sums up what was, I think, a tremendous webinar, and with great advice and great sharing of opportunities for all of us to participate in important global health priorities around this pandemic, and as Dr. Adhikari said, future pandemics, which I think we can all anticipate. So on that, on behalf of the MECOR and the ATS staff, I would like to thank all of tonight's presenters and panelists for their perspectives, their recommendations, and their strategies.
Thank you. Thank you for having us.
Thank you very much.
We'd like to invite everyone to join us for future MECOR and ATS webinars, with the next webinar being on the topic of COVID-19 global perspectives, specifically from Latin America and others. So thank you so much, and stay tuned for what those next ATS webinars and for global health will be. Thank you. Good day, everyone.
Thank you. Bye-bye.
Bye-bye. Thank you.
Bye-bye.
Stay safe.
You bet. You too.
Bye-bye.